Thanks to all the audience who follows our broadcast. We have the honor today of having Dr. David Adelson. Dr. Adelson is director of the Barrow Neurological Institute at Phoenix Children's Hospital, Diane and Bruce Hall Endowed Chair for Pediatric Neurosciences, and the Chief of Pediatric Neurosurgery at Phoenix Children's Hospital. Now, at the 2021 IWBNC, Dr. Adelson is going to share his lecture titled Epilepsy Surgery in Children, Innovations in Diagnosis and Treatment. Please type right your questions in the Q&A panel. We will read them at the end of Dr. Adelson's intervention. Thank you, Dr. Adelson, for accepting our invitation for the IWBNC. The microphone is all yours.
Well, I'm honored to be here. Thank you for this very generous invitation to be back with you all again. This, I think is epilepsy surgery. I think is particularly exciting, and I think it's because of the wonderful innovations that have come about in both diagnosis and treatment. It's allowed me to reinvent myself, go back and relearn, and come up with new ideas and new approaches, really to provide much improved and broad spectrum care for this very complex population of patients. I do some consultancy for Medtronic, and I will refer to things in the generic with the idea of looking at comparisons in technologies. Obviously, Medtronic is a leader in this area. The surgical treatment of epilepsy, for many of you, you're well known. It's had a long history, dating back to the 19th century. But for the most part, it's been reported in adults. They had good to excellent outcomes in many of the series, and in many instances, really with level 1 data. But interestingly as well, epilepsy is the most common neurologic disorder in childhood. And so there are a significant number of children who are suffering from seizures and from epilepsy. But the reality is that we cannot treat all with just medicines. And so in those instances, surgery needs to be considered as an alternative treatment when medication or conservative treatments fail. The reality is, and these are the takeaway points that I'd like for you to have today, is that the best outcomes come with accurate localization of the seizure network. Obviously, our newest innovations have been in the areas of solutions of improved diagnostic accuracy, and I'll point out these. As well, more minimally invasive surgical innovations have allowed us to not only pinpoint where we are able to treat these individual seizures, but also lessen the morbidity. And I'll give some examples of that. And then really it's been the explosion of neuromodulation over the last number of years that has really opened up the opportunity to treat some children who would not have otherwise been treated before. And so I think that this is really the exciting parts about epilepsy surgery that really, I think, are really at its early period of further technology and further opportunities. For those of you who well familiar, this is sort of a pie chart showing that if you have epilepsy, in about half cases, you will be seizure-free with the first drug. If you have to go on to a second drug, there's only an 11% chance that you'll become seizure-free with a second drug. If you have to go to a third drug, there's now only a 4% chance. So collectively, only about 2/3 of patients will become seizure-free with medication. As you can see, that leaves a very large percentage of patients that are refractory to medication management, and we do need to consider alternative treatments. If we sort of look at the treatment gap then, and at least in the United States, if we were to look at epilepsy prevalence, so there's about 3 million patients living with epilepsy. If we were to use those percentages, that would mean that there's about 100,000 that are refractory epilepsy. In the United States, we do about 3,000 epilepsy surgeries per year for treatment. Only about 4,000 cases where we're trying to neuromodulate, so we're not trying to cure, but what we're trying to do is try to lessen or the frequency or the intensity. And you can see this significant treatment gap of patients that are not getting treatment. Again, using these percentages, if we calculate based on incidence, about 150,000 new cases per year, that means 50,000 new cases that are going to end up being intractable. You can see this gap of patients that are not getting adequate treatment for their epilepsy. So I think that there's great opportunity, and I would argue that there's great opportunity not just in the United States but across the world for this population of patients, particularly in children. And this is despite the fact that we have randomized controlled trials in epilepsy, but there's been a real reticence, and it's unclear why, when one has this type of data that's now 20 years old, that shows that patients with surgery did much better, not only from an outcome perspective, but also in a morbidity and mortality perspective than continued medical therapy, that these type of surgeries are not recommended more often. Well, with regards to children, I think that, as we know, there can be some differences between adult epilepsies versus pediatric, and I won't belabor these, but suffice it to say is that many more of these children are living into adulthood, and so there are a number of adults that have diffuse generalized seizure types that have had a whole lifetime, 20 years plus, of intractable seizures where they've not gotten adequate treatment. And so I would argue that epilepsy surgery in children is really what we're trying to do is prevent chronic epilepsy and the impact of epilepsy on the adult population as it ages. And so we truly need to identify early and start to treat early so that we can improve the long-term outcomes for these patients. The goals of any epilepsy intervention is, whether it be medication, whether it be diet, whether it be alternative treatments, or surgery, it is to stop the seizures. So we want to decrease the frequency, we want to decrease the intensity, and the goal of stopping the seizures is to prevent further brain injury. We know that seizures do cause long-term impact on brain function. Having seizures creates abnormal seizure networks. Those seizure networks can kindle and get worse and can spread and can extend. And in those instances, clearly we want to try to lower that impact. As well, epilepsy is a potentially fatal disease. There are a number of patients that will die from their epilepsy. SUDEP is a well-known entity, and so our goal with stopping the seizures is to prevent them from dying. And in children, obviously the early and complete cessation of their seizures allows for more normal neural development. So improved neurocognitive function, improved interaction, improved socialization, gives them the best opportunity for higher quality of life as well as for potential vocational choices. So with epilepsy surgery, obviously the best option for those that are qualified candidates are those that have failed medication, that the seizure focus is well targeted, and that they're focal in nature. Now that's the best option for the best qualified, but it does not mean that other patients are not potential candidates for surgical intervention. As I mentioned, the best outcomes are really if there's a targeted area that we can identify, but our limitation has been the ability to visualize. Well, we can visualize pathologic substrates, but our goals now are to recognize that epilepsy is indeed a functional disorder. And so in those instances, we have to be able to identify the functional abnormalities. And so we have to identify not just the epileptic focus, but to look at the epileptic zone, the epileptic network, in order for us to treat these patients. This is, I believe, where a lot of the excitement has come, is that we've now able to have a number of technologies that allow for better focused localization, that there's a better network identification. And that's been because our electrophysiologic studies have improved, and I'll talk about a few of those. Our anatomic imaging has improved, which has allowed us to identify lesions that we may not have seen before, dysplasias, deep to sulcus dysplasias, as well as it gives us some targeting, so knowing where the normal tracks are so that we can potentially avoid those or come up with more minimally invasive surgical strategies to approach some of these areas. Our functional imaging has improved, and I'll show some examples of those. And as well, we're able to now map and identify where eloquent areas of cortex are. And I think that these are some of the exciting technologies that, whether they may not be at the absolute use in your institutions at this time, these are the things that are coming on in the future that I think will provide further excitement, further opportunity for us as neurosurgeons to have a more targeted approach to our surgical interventions. I'm going to talk a little bit about neuroimaging. I mean, typical MRI looks pretty normal. There's not really much issue. You have different sequences. Now you start to identify areas of potential cortical dysplasia. We can have obviously different directionality. We can localize these areas and then start to think about what a surgical strategy may include. Similarly, we now can do cortical thickness maps, so we can start to identify. So here's areas. This was a patient we placed grids in. We overlaid this with a 3D image of this child's brain. And we were now starting to be able to look at where there were abnormal areas of cortical thickness, so potential areas of cortical dysplasia. And then we can also map in where was the motor cortex. So we can see motor cortex, abnormal areas of cortex. How do we now map that in to where the abnormality is on the electrophysiology? Now you can start to see we're getting a much richer picture for identifying a seizure network and for potential surgical intervention. Obviously, DTI allows us for different strategies to look at pathways and targeting, and I won't belabor it for this group. But suffice it to say, as our targeting gets better and as our understanding of safe approaches gets better, you can now imagine that surgery, we can come up with strategies for improved treatment. Again, to reiterate, epilepsy is a functional disease. It's an abnormal function of the brain, so functional imaging is paramount. There have been a lot of technologies that have been around for a number of years. PET scan, when I was in training, came on the forefront. And, here very succinctly, left temporal hypometabolism. If there's a mesiotemporal sclerosis in this area, very easy to go forward with a surgical intervention. We can now marry PET and other modalities here, MRI, so we can actually lay one onto another, and so we can see areas of hypometabolism and look for either anatomical abnormalities or start to look at what might be areas for safe ingress for surgery. But here, identifying a functional anomaly, giving us an anatomical map, allowing for potentially more safe surgical intervention. SPECT has also been around for a number of years, not particularly sensitive or specific for seizure focus. This is interictal SPECT, maybe a little bit of low blood flow in that particular region. Now with an ictal SPECT, maybe now there's high flow in this area, increased sensitivity and specificity. But you now can imagine with improved technologies, we could do a subtraction image. So subtract the interictal SPECT from the ictal SPECT. And now you have a very nice targeted area. If we now take that modality and we map it onto the MRI, well, now we have a very targeted, specific location that gives us a hypothesis of a potential seizure origin, seizure focus that we could go after surgically. So how do we then also look at functional imaging and use it to highlight for us functional areas or eloquent areas of cortex? Well, I'm dating myself because when I was a resident, we were using these type of, with Wada testing, doing task-based function to put one side of the brain to sleep and see if memory or language would have some impact. But clearly, that's where functional MRI and now task-based functional MRI has come on. It's been a very exciting technology over the last 20 years, and I think that it continues to improve. And in many ways, I think that for at least language and for some of the other modalities, it's really supplanted Wada as a modality. I think for memory, that one is still a challenge, and we still, in some cases, would consider Wadas in those patients. But Wada testing and functional imaging, functional MRI, task-based, is very difficult to do in children. You're not going to get a 6-year-old to cooperate with you in an MRI, stay still enough in order to get quality images. This is a task-based functional MRI in a teenager. We can start to look at where there are motor areas relative to lesions, and so we can start to map out where there may be safe areas for us to go, and also what our eloquent areas of limit are in particular patients. And this is an area, this other area now, resting state functional MRI, is an area that we're very excited about. This is, we're fortunate with a woman, Marina Burwinkle, here at Phoenix Children's, really leading the effort in this area. This uses, again, blood flow differences, looking at normal networks and subtracting those from, or looking at analyzing those in relation to what may be potentially abnormal networks. So at least with resting state, we can start to identify normal areas of the brain, so normal networks. And so if you've got these maps, we can start to identify where there are functional areas of the brain, where the normal functions in patients that don't need to be awake for us to be able to identify these normal networks. We can start to look at language in these patients. And so here in this instance, we can see left language dominance in this particular patient. Again, now having an idea that this is a left language dominant patient, depending on what where your seizures are coming from, develop strategies in that regard. And similarly, we can start to localize where there are abnormal networks. So if we know where the normal networks are, now we identify networks that are not functioning properly, that are using a lot of blood flow. Bold signal is higher in those areas. And you can see here, left temporal lobe localization of an abnormal seizure network for this particular patient. And this is an instance where we use resting state in order to look at the relationship of the seizure network to a tumor. And so here we can identify where the seizures are coming from. So not only go ahead and treat the tumor in this particular case, but also look to try to cure their epilepsy in this instance, knowing where their seizure network has a high likelihood of being. Let's move on to some of the innovations that we've seen in surgery. And again, some of these have been in diagnostic invasive imaging, monitoring, excuse me. This is where we've done surgical implantation for patients in order to identify better their seizure network and particularly its relationship to eloquent cortex. We would do invasive monitoring if there was insufficient data to either lateralize or localize the seizures. If there was a non-concordance of data, and I'll give you some examples of that coming up, as well as do we have insufficient information of the relationship of that seizure network to eloquent areas of cortex. So these would be 3 examples of why and would be indication for invasive monitoring. These are some of the different methods, and I won't belabor them, not in this talk, but suffice it to say is that there are many opportunities for us to try to map this out. Again, I'm dating myself. While this is not the patient, but this was a similar example of what I was doing in my first cases in neurosurgery as in training. We were using air ventriculograms and angiograms in order to place depth electrodes. We've clearly come a long way since then. Here's an example. This is a 14-year-old who interestingly had EEG that was pointing frontally, but had a lesion that was back here parietally. We had a MEG scan that seemed to localize to that area, but now we'd had non-concordance of data. And so, what do you do with that information? So we did come up with a stereo strategy. We placed electrodes in and around that lesion. We placed some frontally as well as on the contralateral side. And in reality, it did localize to that focus. And we ended up doing a very focal resection in this patient who has remained seizure-free now about 4 or 5 years out from surgery. Again, SEEG can be very helpful in a lot of different ways. Here's a more recent example, patient with a bilateral strategy. We couldn't really lateralize the seizures in this particular patient. What we found, again, this is some of just where the different electrodes are placed with maps with 3D reconstructions. In this particular patient, we started to look at high frequency oscillations. And what you can see is that we got high frequency oscillations bilaterally, so indicating bilateral disease. And in particular, we got high frequency oscillations diffusely on the left, but really in a very targeted area on the right. And so in this particular patient, we did a very unique strategy of doing a hybrid DBS, deep brain stimulation, as well as responsive neurostimulation strategy with an electrode in the left thalamus and a surface electrode along the right amygdala. So again, using this whole gamut of information and providing a very individualized, targeted approach toward treatment. Well, let me go into what are the surgical treatments. Again, dating myself. So when I started my career, this is kind of what we could do. We had good results. I mean, overall, if we look at temporal lobectomy, in my early series of temporal lobectomy in children, we had about an 89% seizure-free or rare, non-debilitating, Engle class 1 type seizure outcome. And indeed, mortality was less in those patients with regards to SUDEP. And so for that reason, you have good results. And now, how do you extend those results? Well, in this day and age, if we sort of look at where we are in the present stage, we no longer do anatomical hemispherectomies. We move from functional hemispherectomies to now cerebral hemispherotomies, which are a much more disconnective type procedure. We're doing laser ablations, particularly when we identify dysplasias or very targeted foci in these patients. And as well, neuromodulation has come on in the last 20 years, where now we have a real significant number of opportunities and allow us for increased strategies for treatment of these complex patients. Obviously, I don't have time during this time to go over every single one of these, but I'm going to talk a little bit about more of the minimally invasive ones. Again, for us, with regards to laser ablation, this has come on, well in the last number of years. It has really been a game changer particularly for children with very deep targets. So simply put, it's a stereotactic placement of a laser probe, use of MR thermography in order for us to move ahead and ablate a particular area, ablate a particular target. It was really well established early on, 10, 12 years ago in hypothalamic hamartomas, but now there's a much more extensive use of it for other types of targets. Here's an example. This is a 14-year-old young woman that from Hawaii that we recently treated about a year ago. She came for evaluation, but she had had seizures for 13 plus years and was having 6 seizures a day, these gelastic type seizures. No medications helped. She was eventually sent to us for evaluation. Actually, the family found us online. EEG was really non-localizing. And so, you know, again, perfectly normal child with really significant epilepsy burden, you know, where do we go from here? Here's the anatomical imaging. You can see the hypothalamic hamartoma indicated here. Here's another coronal image showing the mammillary bodies in relation to the HH. Obviously, very, very potentially high morbidity area, and so really would be a potentially high risk with either open or endoscopic intervention. Here's the sagittal images again showing the HH and the mammillary bodies with the fornices relative to that lesion. We did go ahead and do a resting state in this patient, and this showed us that the network was indicating a posterior connectivity. So we did a sample analysis of that and really looking at the directionality of the seizure network. And we can see here really where our connections are that we would need to target in this particular patient. So you can see here, this is our laser probe. You can see the HH. Here's our mammillary body with our fornix right here. But our connectivity really indicated abnormality at the top end of the HH. And so here's our damage maps. And you can see we targeted the connectivity of this HH case. This patient did very well, immediately had cessation of her gelastic seizures, has had no memory problems, no neurocognition issues, has done very, very well. Here's another patient when we start to think of how we might extend this technology, a 17-year-old who had a febrile seizure at 8 months of age and has had numerous years of temporal lobe epilepsy. They were family was very reticent of having surgery because of poor interaction with a neurologist who told them that it was a death sentence to undergo surgery. We went through this whole evaluation, which was very targeted to left temporal lobe. Here's the MTS. You can see on the imaging on the MRI. And then this was the laser ablation of a very targeted area. And again, this patient suffered no memory problems after surgery, was seizure-free, and is remained seizure-free now 2 years out from this ablation. Here's the DWI afterward, as well as the T1 with contrast after showing the extent of the ablation of his mesiotemporal lobe. Laser ablation can also be used for cortical dysplasias. Here's just a sample, a deep to sulcus, cortical dysplasia, gyrus that we were able to target. Here we actually used a number of probes to get a fairly extensive area of ablation. Again, in a patient with a very targeted abnormality, we were able to obtain a significant improvement in their seizure syndrome. But again, as the technology improves and as well as our targeting and our understanding, here's a patient with Lennox Gastaut and atonic seizures. This would be a perfect candidate for a corpus callosotomy. It's really, callosotomy is my favorite procedure, open procedure. Nice views, nice ability, beautiful anatomy, very elegant surgery to be able to maintain the ventricular walls and get an excellent disconnection. But the reality is that it also could potentially be used laser ablation could be used for callosotomy. And so here's a number of our different targets and how we approach this. You can see the extent of the ablations. And in this patient, here's just the images after the ablation. And again, we were able to stop his atonic seizures with this strategy. But not all patients can undergo these type of ablative, resective, or disconnective procedures. I think there are a number of different challenges that we have to take into account. And in those instances, I think neuromodulation is really a potential recommended approach. Not only that, since neuromodulation is not destructive or ablative or disconnective from that perspective, it can be used in conjunction with other strategies. And so, again, do not look at any of these surgeries as in isolation. They can be done in combination with others, like we did in the patient with the Lennox Gastaut that I just showed. There was a patient that ended up getting a callosotomy and a vagal nerve stimulator in order to try to treat their seizures. I think the technologies are improving. I think this is a very exciting area and one that has really helped me reinvent my career and retrain. And every year we add new technologies, and I think that's what's really kind of exciting about this. As I mentioned, there are a number of different neuromodulation strategies, and I would, whether it be VNS, RNS, DBS, or hybrids, I think that there's really great opportunities in this regard. VNS has been around a long time. It's been over 20-year experience. There should be no discussion, no controversy with regards to its use. When one gets to a third medication and there's only a 4% chance of getting any sense of seizure control with another medication or another treatment, vagal nerve stimulation, where 50% of patients are going to get a better than 50% reduction in their seizures, and this is with long-term studies over 2 years, there's no reason that one should not consider VNS in those particular patients, not doing away with medications, not doing away with diet or CBD or any of the other alternative treatments, but as part of the combination to try to lessen their seizures. And so I would argue that VNS should be a primary strategy, very low risk, very high potential efficacy for those patients. DBS and RNS are now coming on the scene. We know that deep brain stimulation is recently approved in the United States for anterior thalamus, for targeting, for intractable epilepsy. It really has had a positive effect. We know that it can be done safely because it has a long history with our movement disorders patients, those with Parkinson's, etc. Now using it for epilepsy, this is an important area that we need to move forward with. Again, we've also looked at hybrid potential, and so the use of thalamic stimulation with DBS, and now marrying these two technologies. Again, what makes this exciting is that anterior thalamus, as mentioned, is really been the primary target, but we also start to recognize that centromedian nucleus, as well as the pulvinar, again, depending on the seizures, so individualizing, targeting your neuromodulation strategy is dependent on the types of patients that you're dealing with. Again, there's some good early experience. I am not saying that this is well proven, but at least from the perspective of being able to offer what is in many instances for some of these very, very severely affected individuals who are seizing all the time. And in some children, we're having them, they'll have 60 seizures a day. Well, then we need to come up with a better strategy. And again, different areas, anterior thalamus, centromedian nucleus, pulvinar as different opportunities. This is the patient that I mentioned earlier. This was a 15-year-old. She'd had seizure onset at 10 years of age after an autoimmune encephalitis. She'd already been tried on a multitude of medications, She'd been tried on diet. She'd been tried on VNS, really was failing and was continuing to have a multitude of seizures. I mentioned earlier, here's her SEEG maps that I showed you earlier. Again, we were able to target the different locations of where her seizures were coming from. And in this instance, we were able to target, here you can see the centromedian nucleus on the left, targeted well with the depth electrode, and then a surface electrode in the area of the right amygdala. And in this patient, we've been able to pick up the seizures, give her responsive neurostimulation, and her seizures are under much, much better control. She has now a better than 90% control of her seizures with this strategy, but also with VNS, and she's on medication and she remains on a diet. So again, thinking globally, it's not just about whether one procedure, one medication, one strategy, it's about how do we globally look at these patients. And then lastly, with regards to kind of coming full circle, how do we have better accuracy and efficiency? I think a new exciting area is really the neurosurgery robotic systems. There's a number of them out there. Again, you have to choose based on kind of what is your institution's preferences and opportunities for use. In our decision making, we had a number of different areas that we wanted to try to marry in. We ended up going with the stealth auto guide in this particular instance. Here's the robotic device here in use for our targeting. We use it primarily for our SEEG and for some of our more superficial targets. I would argue, I'm not yet convinced for my deep targets, and I still do frame-based placement of electrodes for deep targets, such as small HHs, as well as for thalamic DBS. We've been using it now over about a year and a half, and there is a learning curve to it, but I think because we were already familiar with the image guidance system that it is primarily involved in, we've been able to expand it to multiple type cases. Showing you again earlier, this was as I mentioned, the laser ablation case I showed earlier using a 3mm probe. Here it is married out of the match to planning. We had really good targeting in this instance, but you can see this was our plan. Here was our target, maybe about 1.5 mm, 2 millimeters off. In a very small target, that might and would be a significant issue. In this particular instance, it was not. It actually married up well with our seizure network, but you need to take that into consideration when you're deciding on robotics. So let me end in saying that we absolutely know that intractable epilepsy significantly impacts mortality, impacts morbidity, and impacts quality of life. And particularly in children, when one looks at a lifetime of seizures and one looks at the impact on their ability to get employment, their ability to interact and socialize, their impact on school, those kinds of things, there is no question that intractable epilepsy has the potential for being not just a fatal disease, but a lifelong impactful disease that truly needs to be aggressively treated. We know that outcomes from surgery are better when compared to continued failed medical therapy, and that 1/3 of patients are going to fail medical therapy and should be considered for surgical intervention. We know that good outcomes lead to whole new lives, and there's not even a question of that. I think what I've hopefully shown you is that future advances, or at least present day advances, have already allowed us to solve many questions, to localize better the seizure focus, the seizure networks. And as a result, we've, with more minimally invasive approaches, with new technologies, we now have a much larger menu of surgical options that we can do in combination in order to optimize the care of these patients. One could not do it without a team. We've got a great team here at Phoenix Children's Hospital that really allows us to provide comprehensive care, to do everything from diagnosis to medical management, to diet, to alternative treatments, to surgery, to rehabilitation. All of these specialists have really contributed to why I believe we have great outcomes here. But it's really because of their dedication to the advancement of epilepsy care in children. And so with that, I thank you for your attention, and especially the invitation to be with you here this morning.
Thank you very much for such a wonderful lecture, Dr. Adelson. I'm sure all the audience has learned from your robust experience. Right now, we have a few questions from the public. Let's see. Dr. Andraus is asking, thank you, Dr. Adelson, for this amazing lecture. Is there any general time window in which you expect to see reduction in the number of seizures in patients after surgical procedures, or is it specific for every patient?
I think it's specific for patients, but it's also specific to procedure. So, for example, temporal lobectomy, we usually say that you'd love to see immediate response, but you know, again, because they have a seizure network, so you have a focus with a spread. Even though you may take the seizure focus, there may still be irritability along the network, and until you keep the seizures at bay for a period of time to allow that seizure network to die back, I think that's really why you'll see seizures in the early period after, let's say, surgical resection. For neuromodulation, I think it takes a while longer because what you're trying to do is interfere with the seizures. So for vagal nerve stimulation, I usually say we don't consider it a failure till they've had no change in their seizure outcome for about a year or two after implantation.
Thank you. Dr. Gupta is asking, Dr. Adelson, how do you determine the exact number of stereo EEG electrodes required for a good registration? Thank you.
That's another great question. Again, it depends on your hypothesis. I think one of the wonderful things about our localization and our network identification technologies and innovations right now is that it's allowing us to hone in our targeted strategy. So, for example, that patient that I showed with the lesion in the parietal area, you know, now with all of our data, we were able, if you saw there, we had a very, very concentrated SEEG strategy. It was really around the area of the lesion. But it still covered frontal, parietal, contralateral, but much more concentrated. If I'd gone just based on EEG and MRI, I would have been putting electrodes bilaterally in frontal lobe, parietal lobe, temporal, occipital. Here, we were able to do a very targeted approach with our electrodes. So I think it's, again, I think what makes this exciting is the fact that we can individualize and target patients much better than we could in the past.
Thank you, Dr. Adelson. But I want to ask, for in your practice generally, how many electrodes do you usually, like it's for like the minimum and the maximum electrodes you usually use?
I usually say a minimum of 8 to 10 electrodes per side. So if I'm doing a unilateral strategy, it's about 8 to 10 electrodes. If I'm going to do a bilateral strategy, then it has to be, a good 16 to 20 electrodes. And that's so that you get good matching. If you're doing bilateral, it's matching electrodes, frontal, orbital frontal, amygdala, hippocampal, insula, middle frontal, posterior frontal, that kind of thing. If I do a targeted approach, unilateral, then it's 8 to 10, because you really want to, and if I can get a more concentrated approach, it allows me to see onset as well as spread.
Thank you. Dr. Atwood is asking, is there a role of artificial intelligence in evaluation of seizure network?
So that's a great question, and I didn't touch on that. We have some people who are looking into that technology, or looking at that potential technology. I do think that that's something that we're going to start to see in about 3 to 5 years. Again, a lot of the times we depend on the neurologist to read that EEG and tell us that that looks like a seizure. And I think that AI is going to allow us to do improved, not just on surface, on scalp EEG, but on these SEEG electrodes. Like I showed that picture of the high frequency oscillations. I think AI is going to be able to better pull those in the whole gamut of EEG. That HFO, for example, that's when we identified a seizure in that patient. We then did the analysis at a high frequency in order for us to know that that was an HFO in that region. I think AI is going to be able to pull those out. It's going to tell us that the patient had a seizure, that there were high frequency oscillations in those particular electrodes, which electrodes those were, so that we can do a very, very targeted ablation or a targeted resection or a targeted neuromodulation strategy in those patients.
And I have another question. In RNS, for example, do you think the interpretation of the RNS registration could be also could be the artificial intelligence used for the interpretation of RNS as well?
I do. I think that right now the RNS is reading the seizures, or reading the patient's baseline EEG, and that's ongoing. And what's very exciting, again, it's dependent on expertise, and you do get variability of expertise across neurologists and their understanding of what's going on. I think what's really exciting, for example, we did a DBS using the RNS system in a child who had fires and bilateral centromedian nuclei, and had marked and significant bursts of abnormal electrical activity coming out of the thalamus bilaterally, but more so on the right than the left. Those are instances where AI would be able to more quickly identify those bursts and then provide the neuromodulation stimulation strategy to address that.
Thank you. Dr. Clark is asking, in regard with the case of the child with elastic seizures and hypothalamic hamartoma, what are the main complications you should follow after therapy with laser interstitial thermal therapy?
Sorry, say that again.
In regard with the case of the child with elastic seizures and hypothalamic hamartoma, what are the main complications you should follow after therapy with laser thermal ablation? Yes,
I'm sorry. Yeah, but that is a great question, a very important one. So what we are able to do is we put safety targets on the mammillary body, the fornices, and on the optic apparatus. So obviously, there are three main potential complications of HH, particularly when you do ablations of very large hypothalamic hamartomas. So we do neuropsych evaluations pre and post-operatively on all the patients. Obviously, visual function is important, but the the most important, really, and the one that we're most concerned about is hypothalamic function. And so we do endocrine panels in all of the patients pre and post-operatively to evaluate them. I also treat them with steroids pre and post-operatively for swelling, but also for stress, potential for cortisol and difficulties. So I think that those are really the big ones that we're most concerned about with HH cases and laser ablation. And
Thank
that's
you.
also why we don't do a
Sorry.
very, very large ablation. We are looking at only targeting the connections, the network. So when even on a large HH, we do not go in to ablate the whole hypothalamic hamartoma. We are only interested in where the HH connects to the brain and how it's creating the seizure network. So in a large HH, we may only get maybe 25% of the HH, because what we're trying to do is target where that network is. And that's why our resting state has been very, very helpful in creating that targeted area. We don't have to blast away there and potentially cause damage.
Right. Trish Nalim asks, who are the best candidates for VNS?
So for VNS, for those patients that have failed 2 or more medications, who may have also failed diet and alternative treatments, I think that there's not a targeted area that you can identify. So let's say non-lesional epilepsy, and I put non-lesional in quotes because we just haven't been able to identify it, whether it be on anatomical or functional imaging. I think that it's a very low risk, very high potential efficacious procedure. So it's usually the procedure we recommend first, and it does not preclude them from having further treatment or further investigation. So patient where there are low potential for identifying a seizure focus or a network, we'll put a VNS in, see if they get a response. If they don't, then we'll go ahead with a bilateral SEEG strategy. I think SEEG has a higher risk than VNS. And so, that's kind of been our approach. If we are able to lateralize, then we can do a second strategy to look at, localizing seizures. But we usually will do VNS, then consider SEEG if we're going to potentially go to a DBS type strategy.
Right. Dr. Sanchez asked, thank you, Dr. Adelson. What is the role of closed loop DBS in seizure surgery?
Well, I think this is a very exciting area. Closed loop, what Dr. Sanchez is mentioning is that what you're doing is that you're reading when the patient is having a seizure. So you have to have electrical activity that arises from the either seizure focus or the thalamus that then sets off the stimulator to give a responsive stimulation. So the instance that I showed there is a closed loop system. The VNS is an open loop system. So in that instance, the VNS gives stimulation whether you need it or not at a constant paradigm or pathway. So let's say 30 seconds on, 3 minutes off, that kind of thing. VNS has a partial closed loop system also, in that it has a heart rate capture capability, so that when patients whose seizures are coming on, their heart rate jumps because of sympathetic activity, the VNS can read that and give an extra stimulation for it. So it's a partial closed loop system. So those are where I think new innovations are coming. I kind of mentioned it a little bit of the challenges for neuromodulation. It's the open loop versus closed loop. And I think that one or the other and or combination thereof, like with VNS and with DBS, I think will be where we're going in the future. And I think it's a matter of having a way to better recognize that the seizure is coming on and giving a neuromodulatory stimulus to inhibit the seizure from going beyond the initial focus, beyond the network, keeping it well contained so that it doesn't interfere with function.
Thank you. Dr. Nadine is asking, is there any set of metabolite assay we should perform to rule out metabolic causes of seizures?
So that's a great question. You know, I think that some of the future is it's part of the initial diagnosis is you know, why certain patients are more prone to have epilepsy and seizures, and also with the change in their seizures. And so I think genetic testing is being done more frequently. I think now some of the epigenetic phenomenon and looking at different metabolites and looking at different biomarkers of not just seizure onset, but seizure or epilepsy evolution is really the future excitement. So for example, somebody who never had seizures and suffers a traumatic brain injury, they have a higher incidence, about 20%, of forming into a post-traumatic epilepsy. And so how do we identify those patients that are now are at risk for developing post-traumatic epilepsy, and then how can we interfere or prevent them from going on to either having a very bad case of seizures versus can we prevent it completely and not have it at all? So.
Fantastic. Dr. Madriñán is asking, is there a role of MRI spectroscopy in the evaluation of the seizure network?
Yeah, I just alluded to it. I think our MR technologies are getting better and better. So looking at, I showed anatomic abnormalities and I showed functional abnormalities with MRI. Metabolites and looking at metabolism of certain areas that we just haven't defined yet. Obviously lesional, if you want to know whether something is hypometabolic versus hypermetabolic, you know, MR spectroscopy can be helpful in those instances. Different metabolites, as mentioned earlier, that can be picked up with MR spectroscopy. We don't use it per se. I know that it's out there and that it's has been exciting for a number of individuals in different centers. It's just not widespread right now.
Great. Another question, very important for us, on what are the most important, what are the most critical characteristics or resources and personnel to be able to start an epilepsy surgery clinic for you, in your opinion?
Yeah, I mean, I'm very, very lucky. You know, we have a wonderful, dedicated team. I think that simply put, you know, you obviously need an excellent neurologist who is really focused and well-versed in epilepsy. And I think that that's very important. The second is, again, good neuroimaging. I really do think that a vast majority of our patients can be identified with areas of lesional abnormality with just EEG, and you know, then obviously a surgeon who feels comfortable with the different strategies for either diagnosis or surgical management. So you know, I think at a minimum you need that. You know, having, you know, good neuro ICU and neuropsychology and good neurophysiology, you know, all of those are important as well. And that is another layer that allows you to maybe get into more complex patients, you know, those that, you know, require a bit more of a comprehensive either evaluation or ongoing management.
Thank you. And the last question, in middle to low-income countries, it's difficult to have robotic assistance for stereo EEG. Do you consider it's feasible to start using stereotactic frame for stereo EEG? And how many electrodes do you consider is the minimum to use for using this technique?
So that's a great question. And so we used to use the frame, and obviously it takes a long while to do it intraoperatively. I think that, and I would absolutely agree, the robotic has helped us on an efficiency and speed. What's different about it is, or not different, it depends on your perspective. It's allowed me to do my surgical planning in the operating room at the time that the patient basically is at the hospital. With the stereotactic frame, many instances I was doing my planning the night before. I think that you don't need a robot for SEEG because you're not really looking for millimeter accuracy or sub-millimeter accuracy. I think you need just millimeter accuracy, and you can do that with image guidance. If you've got a brain lab or a stealth system or any of the other image guidance systems, which I think most places would have access to those technologies, you can put in electrodes safely freehand in order to be able to monitor more electrodes in more instances. So yes, simply put, one could use a Lexel frame and place a multitude of electrodes. It requires a lot of preoperative planning so that you're not caught in the middle of the operating room trying to, kind of figure it out. I think that you don't need robotic systems to place SEEG electrodes. I think that things like a Vertec arm or freehand placement of the electrodes can be done safely in the appropriate circumstances. Would I put in a freehand electrode right up against vena labae? Absolutely not. I would want to have, at least a couple of millimeters safety margin, right on the top of the gyrus, in order to make sure that I had a much lower likelihood of causing a major problem. Our electrode bleed rate is about 0.1 to 0.3% per electrode. We've had, fortunately, 0 instances of needing to go back to the OR for a hematoma or something like that. Have we had small hemorrhages? Yes, but none that were clinically significant. Having said that, those numbers include when we used to do freehand placement of electrodes. And in some instances, we were probably much more conservative with the freehand approach, and our hemorrhage rate was a little bit lower. With the robot, I think we get a little bit cavalier, a little bit brave to be a little closer to potential areas. And so I think our bleed rate is maybe a little bit higher actually with the robot. Because of that, we kind of got a little, maybe a little too cocky, and maybe we need to be a little bit more conservative again. But again, we've never had anybody need to go back, whether with the robot or not, for evacuation of a hematoma.
Great. Okay, Dr. Alson, on behalf of CIEN, I would like to thank you again. This has been a wonderful lecture, and we are really grateful and honored for your participation in the 2021 IWBNC.
Well, it's so nice to see you all again, and particularly you. You always moderate my sessions, so I appreciate it, and thank you for the invitation. You all have a great meeting.
Thank you. For all the audience, please keep in mind this lecture will be available on our website from the next week. In a few minutes, we will have Dr. Sanai doing his lecture, building an intraoperative mapping program for gliomas. Actually, it's already started. To get the link for this upcoming conference, please follow the link pinned on the chat screen or check the program schedule on our website, cnhus.com. Thank you for all you.